Hi, everybody. My name is Dr. Lorianne Stretch, and I'm going to be reviewing case conceptualization. So what is case conceptualization? Case conceptualization is a way to map your client's case, your client's concerns, presenting issues, and it will help guide your counseling process. Specific counseling theoretical orientations and case conceptualization applied together can help identify the client's difficulties and see where the client's issues started and how they've been maintained, right? It can also help you select interventions that might be appropriate to the client's situation and set goals that you want to achieve with the client collaboratively, right? Also, helps us select evidence-based literature, right? We can use evidence-based literature to support our case conceptualization using current peer-reviewed articles, governmental sources, or even educational sources. But no matter what, we always want to be a critical consumer of that and make sure that it's current research that we're basing this on. So ideally within 5 years, but definitely no more than 10. For this review of case conceptualization, we're going to look at a model called I Can Start. And I Can Start is a way of conceptualizing your clients. So first I have to understand myself, the I, then the C, the context of the client, the A is the assessment and diagnosis, N stands for the necessary level of care, S is the strength-based focus that hopefully all counselors have, T is treatment approach, A is the aim and objectives of that treatment, R is the research-based interventions, and T is the therapeutic support services. So we're going to look at each one of these in a little bit more detail, starting with I, counselor. So as a counselor, I need to come to the counseling relationship with the wellness focus. That means I need to be aware of my biases and my stereotypes, and so that I can really see the client's strengths and resources. I also need to have a prevention focus, a focus on, wellness and helping the client stay healthy. So that means I have to believe that clients have the ability to heal and that they have the ability to stay well. I can use human development principles to understand where I am developmentally and how that might influence how I see a client's development. I also need to have a holistic approach in the sense that I know that I have tendencies to favor certain perspectives in the world. For example, I have some legal training, so I tend to look at everything from a legalistic perspective or the liability of situations, whereas another colleague might be more tuned to emotions than I am. So by using peer review and supervision, I can get a more holistic perspective of my clients. So I have to recognize I have limitations. I also can look at, what are my ideas about disease and disorder, normal development, and am I going to potentially pathologize something that shouldn't be pathologized, right? Or am I potentially at risk for countertransference? If I say have a family member that has a certain disorder, is that going to impact my relationship with a client who has a similar disorder? I need to know myself. Biopsychosocial perspectives, biologically, socially, emotionally, psychologically, where am I at? Am I healthy? Am I doing well? Because that's going to influence how I see my clients. And then understanding the client-counselor relationship. What's my own cultural view, my world perceptions, my beliefs, and how are those going to differ from or be similar to my client? With also realizing that just because my client may look like me or sound like me doesn't mean they are like me. I have to really set those assumptions aside and really explore that. C for context of assessment. So this is really talking about the client's context, which is really embedded in culture, right? What makes the client up, what's going on in their world, what's happening, right? What are some of the multicultural and social justice aspects that are going on? What's the historical influences that are impacting the client's ability to reach wholeness or wellness in this current day? What are the present day cultural uniquenesses which are, causing issues? And what multiple identities is this person bringing to the session, and how does that interact with my own identities? Really looking for those opportunities for social justice advocacy, not to do for the client, but to understand the client through that lens of what might be going on, right? And how that might be exacerbating what the client's dealing with. My own understanding of self, right? If I don't understand my own culture, cultural humility, I can't possibly understand somebody else's and my interaction with that. And then also kind of where do I have opportunities to be a social change agent, right? We get insight into a lot of people's worlds and we can see patterns and themes of things that need to be changed and what are we doing with that. So understanding the context and applying some of those universal themes to the work we do with clients. And then what does our theoretical lens see, right? Each time we have a theory that we're working from, it's going to influence what we see of our client's case. And it may limit us in some ways. It may help us dig deeper in other ways. So, but knowing those limitations and knowing what the possibilities are can help you choose the right theory in which to look at a client. So this is a video I wanted to share just about how important it is that we unbox our differences. So I'm going to share this. It is mostly subtitles because it's from a different country, but here you go.
Det kræver kun et enkelt blik at sætte folk i bås. Der er os, og der er dem. Dem med de høje indtægter, og dem uden. Dem vi stoler på, og dem vi går udenom. De nye danskere, og dem der altid har været her. Dem fra landet, og dem der aldrig har set en ko. De religiøse, og de selvbevidste. Der er dem, vi deler noget med. Og så er der dem, vi ikke deler noget med. Velkommen. Jeg kommer til at stille jer nogle spørgsmål i dag. Nogle af dem kan godt være lidt personlige, men jeg håber, I vil svare ærligt på dem. Hvem herinde i rummet var klassens klovn? Hvem er bonusforældre? Så er der pludselig os. Os, der tror på et liv efter døden. Os, der har set en UFO. Og alle os, der elsker at danse. Der er os, der er blevet mobbet. Og os, der selv har mobbet. Og så er der os, der er heldige at have fået sex inden for den sidste uge. Os, der er kærestesorger. Os, der er hammernyforelskede. Os, der føler os ensomme. Os, der er biseksuelle. Og os, der anerkender andres mod. Os, der har fundet mening med livet. Og os, der har reddet et liv. Og så er der alle os, der bare elsker Danmark. Så måske har vi alligevel mere til fælles, end vi går rundt og tror. TV2.
So that was a video to just show kind of how we can explore, right, what our similarities and our differences are. But the more we know about ourselves, the more we're able to build bridges with people who may be different from us. But also at the same time, we can begin to recognize that just because somebody looks like us or, seems like they might be like us, that they don't have the same experience as us. You might be surprised by what you find. So just being open to exploring the possibilities, right? And one of the models that you can use to really explore deeply into somebody's cultural context is the addressing model by Hayes. And with the addressing model, it asks you to look at different areas that some you may immediately think of when we talk about the context of somebody's life, but in others you may not naturally go to. So one of them is age and generational influences. Then there's developmental and acquired, issues, concerns that somebody might have, disabilities, religion, ethnicity, socioeconomic status, sexual orientation, indigenous heritage, national origin, and gender. So all of these are important aspects of somebody's culture and context that can really influence who they are and what they bring to the table. And likewise, all of these aspects of you also influence how you're going to receive and interact with your clients. So let's move on to assessment and diagnosis. So with assessment and diagnosis, we begin to try to identify information like what's going on. So we've done an intake, we've collected some basic information. Now let's dig in a little deeper. What's the history of the presenting issue? Has there been past counseling or psychiatric issues? Is there any medical history? What's the family history, right? What's this person's personal context? Who do they live with? What's important to them? We also can do mental status exam, and we can do referrals or other diagnostic criteria as well. So let's look at some of these. So here I have listed for you the level 1 APA measures and the level 2 measures. These tools are going to be really helpful to you. You'll also hear about these in the assessment class. These will help you determine kind of where a client might be at risk for meeting criteria. It definitely isn't a diagnosis in the sense of it's not going to give you a final diagnosis, but it can help you narrow down where it might be and rule out things that aren't the diagnosis. There's also the cultural formulation interview, which I really want to stress is a great way to understand that last section that we were talking about as well. So with the mental status exam, you've got all of these areas that you need to assess with. So a mental status exam is only complete when you've hit all of these areas. Okay, so I want to give you a description of what each one of these are. So appearance, of course, is how do they look? How's their grooming? Are they dressed in a way that seems appropriate? How do they walk? Are they hunched over and kind of appear to like they've got the world on their shoulders? Or are they standing up proud and tall? Kind of what's going on? Orientation, are they aware of time, place, and events? How's their speech? Are they, is it pressured, slurs, flat? What's it sound like? Affect, how are they acting in behavior in their own statements? Are they in any potential for harm? Judgment, are they able to make reasonable, rational decisions? Or is there some sort of, irrational thought going on? Thought processes, reality testing, are they dealing with any delusions, hallucinations, or anything? And then intellectual functioning and memory. I wanted to give you an example. So this is an example of a mental status exam. Client is a 43-year-old woman who looks older than her stated age. She's well groomed, appropriately dressed for a professional interview. She's well oriented. Her speech is slow and labored as if it is painful to talk. She has had an occasional thought of ending it all, but has not made any suicidal plans or preparations. She talks about future events with the expectation to be alive. She's aware that she is depressed and recognizes the source of some of the feeling from the inside moods, although she often refers to the difficulties of her situation. Her thoughts are organized, well presented, with good vocabulary, and she is not psychotic. So no hallucinations or delusions. So you can see this is a comprehensive description of the state of the client. Now, we also need to understand the problem the client's presenting. So here I've given you lots of questions that help you dig into the client. Now, I don't ask these questions one right after the next with my client. These are more guiding questions that I think about that help me kind of structure my exploration of the client's problem. So I'm going to build in reflections and summaries and paraphrasing as I'm kind of navigating through these wonders, right? Like these are things I wonder about. And here's some additional questions that I might ask clients or some variation of these. Now we're going to get a necessary level of care. So once I've collected all this information, assessed, I've diagnosed using the DSM-5 course or DSM-5 TR when that comes out. Now I need to determine, okay, what's the level of care that this person needs, right? And there's a lot of things that are going to contribute to that decision. What's the severity of the diagnosis? What's the severity of their symptoms? What's any physical or medical limitations? Is there suicidal ideation? Is there a plan? Is there homicidal ideation, a plan? Are they able to take care of themselves? What's been their response to past treatment? What are their goals for treatment, right? What social supports and resources do they have? What's their desired level of care? And this can be inpatient, it can be partial inpatient, it can be, some level of outpatient with, additional services. It can be a wide range of things. It's a big continuum of care, but you have to match the client's needs with the type of care that would be most responsive to them. And unfortunately, we also have to take into consideration insurance and resources, because not everybody can afford to be inpatient when they need to be inpatient. So how do we prioritize the resources that the individual has and use those to give the most resource support that we can for the resources that they have? Strength-based. So these would be where I explore how the student or how the client has strengths, right? Like, what are the client strengths? What are my student strengths? What are their short-term goals, their long-term goals? How in the past have they reached those goals? I really want to understand their strengths. I'm going to spend a lot of time understanding their strengths, because usually if you can understand the client's strengths, you can understand the paths that they'll be able to take to achieve the goals they're now facing. Family of origin strengths can also be helpful. What have they admired about their family? What have they learned from their family? What is their family origin? What have they persevered through? These are helpful tools for the client as well. Cultural and community strengths. Also another way of looking at things, like how has this person's community persevered, right? How can the community help the client? All of these are important things to explore when you're looking at the strengths. And then spiritual strengths. What is this client's spiritual strengths? What are their spiritual beliefs? How does their community support them in that? What memories do they have about spirituality and religion? These are parts of ways to explore the strengths. Then we move into treatment approach. Treatment approach is, well, how I'm going to treat the client, right? So this is where I'm going to decide, okay, with the client, what is the primary problems? What is the definition of the problem? And then what's the goal of that problem, right? What are you hoping will be the outcome? And this is where you have to have SMART goals, which we'll talk about in a little bit, but basically they're strategic, measurable, achievable, realistic, and timely. So if I say, I have a goal of paddleboarding again after surgery, that's not a strategic, measurable, achievable, realistic, timely goal. More along the lines of SMART would be something like, by June 30th, I will paddleboard for at least 30 minutes unassisted and stay on the board. Very specific. It's measurable because I know how long I'm going to be paddleboarding. It's achievable because, it gives me enough time between my surgery and the actual event to be able to do that. It's realistic. And it's time-oriented by June 30th. So all of that makes up the SMART goal. So a SMART goal is not a series of statements, but it's one statement that represents all of those things. So treatment planning, collaborative, must be collaborative. It's not a treatment plan if it's not collaborative. It needs to identify what is the severity of what's going on, right? That will determine lots of things, the level of care, how we treat, the interventions we use. And there needs to be alignment. So when I have a problem, then the definition should clearly align with the problem. The goal should clearly align with the definition of the problem. The objective should clearly align with the goal, and the intervention should clearly help me meet the objective. So everything needs to be aligned and connected. Excuse me. Treatment is also dynamic, right? So it shouldn't be a static plan that just sits in the person's file. It should be something that's responsive to the progress or the regression that the client makes in the process of treatment. So good treatment planning really is going to focus on ruling out diagnoses, and then it's also going to be culturally and contextually sensitive to the strengths that the client has. Very important. So my treatment approach, here's some questions to think about. As a counselor, do I understand the client's issues? I think if you haven't staffed it with somebody else, you may not fully understand your client's issues. So that staffing, working with supervisors, working with peer supervision groups is so important to understanding that holistic perspective, right? And then I have to understand, what does the research say about this client? Just the other day, I have a client that I'm working with who is what I would say is a pretty extreme athlete for their age. And, they're worried about their eating. They're wondering if maybe they've developed some sort of eating disorder. Well, I had to go to the literature. I had to go to the literature and see, what does the literature say about eating habits and eating patterns of, athletes who do more extreme sports, and what's normal and what's not normal. Because when I'm looking at an athlete, I can't use just everybody in the general population to determine what's normal. I need to use a population that's similar to my client. And I learned a lot. I really actually kind of got lost in reading the Clinical Sports Psychology Journal and learning a lot about what's the best practices for working with athletes who may have eating disturbances or disorders, and how do I differentiate those and how do I treat it? So you have to go to the literature, right? So I have to understand, what is my treatment approach and what's informing that treatment approach. So let's talk about aim and objectives. So with aim and objectives, this is where I really get into the evidence-based approaches and interventions. What are the objectives that are going to support those goals that I set? So if I have a measurable goal, what's the small steps to get to that goal, right? I'm going to go back to my paddleboard example. So in paddleboarding, there's a lot that you have to have, and balance is one of those things. So if I have a client who wants to paddleboard, which I know is not a counseling example, but we'll just use it as an example, then I have to make sure that they can balance. Let's say they have surgery on their hip, right? Well, they've probably lost a lot of muscle dexterity and muscle balance. So they need to practice that, right? There's going to have to be some objectives that help them reestablish balance. My intervention might be a balance board that I have them stand on for a certain amount of time, right? Or it might be lifting weights on both sides equitably to see where the strength is on both sides. So the interventions and the objectives will support the goal. So each goal will have multiple objectives and possibly multiple interventions. And it's going to be theory driven too. So what does the theory say? I practice dialectical behavioral therapy. So, my theory is going to give me a lot of resources to use in order to inform how I help the client meet the goals that they've set with me. Okay, so it's collaborative. Again, SMART goals and objectives are going to be specific, measurable, attainable, results oriented or realistic, and timely. And that's all those things in one goal. Okay, so a counseling goal that would be SMART is, by July 1st, 2022, the client will be able to utilize a minimum of 3 coping strategies when they are triggered and have a stress response. It's measurable, it's time oriented, it's realistic. I'm not saying they're going to have 20 coping strategies, right? I'm trying to be realistic about what they're going to be able to do. So all those things in one statement. Now, research-based interventions. What is known about the effectiveness of counseling for the specific population, the specific treatment. And then, we know counseling is effective in and of itself, but what do we know about the particular treatments and interventions for treating a particular mental disorder or presenting issue, right? So evidence-based practices and interventions will help us reduce our clients' symptoms, improve their level of functioning, improve their ability to function within their communities and families, right? So these are the gold standards of clinical health, in that the randomized controls trials are going to be the ones that are going to have the most weight, so to speak, in the sense of evidence-based practices. They're certainly not the only evidence-based practices, because not everything we do can really be measured that way, but it is best to start with the controlled trials if they exist. Sometimes we're dealing with things where there hasn't been done much research. So what do we do then, right? So we try to find the best sources of information we can, and we try to be a critical consumer of those resources, okay? So I have some resources here. If you get the PowerPoint, you'll be able to click on these resources to learn more about evidence-based practice versus evidence-based, research type of thing. So you'll get to see the difference. So let's watch a little video to learn a little bit more about what evidence-based practice is and is not.
Evidence-based practice involves using the best available research evidence to inform each stage of clinical decision-making, but also considering specific patient or client variables such as traits, cultural background, and also their treatment preferences. Now, the CPA definition of evidence-based practice is actually a hybrid definition because it defines what evidence-based practice is. And again, this involves using the best available research to inform clinical decisions, but also considering specific client variables. But it also adds that clinicians must track patient progress throughout therapy to determine if the therapy they're offering is actually effective. Now, this progress tracking is what many call practice-based evidence because these data are collected in the clinician's actual practice. What this means is that evidence-based practice, according to the CPA, the Canadian Psychological Association, involves looking at the science, looking at the scientific evidence, looking at patient or client variables, including their treatment preferences, looking at the data about the individual patient's progress and treatment. And what enables us to pull all this together is our clinical judgment and our experience. So there's 4 pillars to evidence-based practice: science and research, patient variables, data about the patient's progress, and then our clinical judgment, of course. Now, unfortunately, many people still believe that evidence-based practice is a bit like a cookbook, meaning that once you have a diagnosis, you look for treatments that have been shown to be effective with that diagnosis. Of course, looking at the science is certainly a big part of evidence-based practice. But as I mentioned earlier, if a clinician stops there, meaning if his clinical reasoning stops at finding a treatment shown to be effective for a given diagnosis, that's not evidence-based practice. That's what we call using empirically supported treatments, or ESTs, which are therapies that have been shown to be effective, that have been shown to work for specific conditions, and they're often presented as lists. So for condition X, for example, treatments 1 and 2 have been shown to be effective, and so on and so forth. But going with an empirically supported treatment model, an EST model, and stopping there, that's not evidence-based practice, because evidence-based practice requires that in addition to this, in addition to looking for good research, you also factor in patient variables, you also use your clinical judgment, and you track patient progress. The point I want to emphasize here, I suppose, is that evidence-based practice is not only going with lists of therapies for different diagnoses. It's not only looking for, not looking only at the science, although science is very, very important. Incidentally, it is not only built on outcome research, because evidence-based practice factors in research on other important variables in therapy, like research on hope and on the therapeutic alliance and so on. And evidence-based practice is simply not a cookbook. So you can see that evidence-based practice in psychology is actually quite complex and sophisticated. It's rigorous, and perhaps more importantly, it is much more comprehensive than what some professionals seem to believe.
Okay. So that's a little bit about what evidence practice is and is not. So again, it's complex. It's not like you're going to be able to just go, to Google Scholar and find an article and it's going to be the be all do all to help you with your client. There's so many different layers that you have to figure out. Like, is this the same thing that my client's presenting with? And how is it different? How is it similar? Was this research done on the same population as my client? And if not, how can I make generalizations to this client and why? What's the rationale for that? So a lot of the classes that you either have or will have in the program are helping you be critical consumers of this so that you can match the issues, the theories, the concepts, the evidence, the practices, all of these things to your client to make the best compilation of all of this information to understand the client and help the client. Okay, let's go on to the next one. There we go. Therapeutic services supports. So this is the things that we can use to supplement the treatment goals. It can be work done in or outside of session. So it could be like education, training, socialization, how to navigate different processes. So like one of my clients recently experienced financial fraud, right? And so I introduced them to the AARP fraud line and kind of walked them through how they could report fraud, and then also introduce them to some of the educational materials about fraud. And so that was, helpful resource to them. It was an addition to the therapy that we were doing, and it gave them research or gave them support that they could use beyond our work together. All right, so that's the I Can Start model. So I think the I Can Start model is probably one of my favorites. I think it's pretty kind of the case conceptualization models. It's one of the more simple ones or simpler ones, and it really allows you to think through different aspects of the case in order to have a holistic perspective. There are other models though, like I like Ingram's model of case conceptualization, which looks at subjective, objective, assessment, treatment planning, diagnosis, ethical considerations, social, cultural considerations, and theoretical orientation. And that's Laura Ingram. I think it's a good model. It's a pretty good overview. There's also the Sperry and Sperry model, which is really popular, and it talks about the predisposition. What are the client's biological, psychological, social, and cultural? What are they bringing to the table? What are the precipitants to what's happening? What are their protective factors and strengths? What is the maladaptive pattern? What are the perpetuants? What things are continuing it, like and reinforcing what's going on? What's the plan? What's the prognosis? And then, I think that their model really is very similar to the other two, and they're just different names, right? But it's the same ideas and same concepts that you're building this plan, this holistic view of your client. When you get the PowerPoint, you can click on this particular article and it will take you to a Counseling Today article that Sperry and Sperry wrote, and will walk you through their model and also give you concrete examples of what that might look like. So it's a really helpful resource. So this gives you some really great tips for effective case conceptualization writing. So here's an outline of case conceptualization. What's your theoretical orientation, right? Like keep it simple. What's the evidence? This is where we want you to use primary sources, right? Like what did Adler say about Adlerian theory? What did Ellis say about RABT? So make sure you're using some of the primary sources to really understand the theory and not relying on textbooks that talk about what somebody else talked about the theory, right? We want to hear it from the people who were creating the theory, people who were using the theory in the field. So another great resource there is like the theoretical institutes, right? Like the Gestalt Institute or something like that. What's your literature review, right? What literature do you understand about this theory? What literature do you understand about the presenting issue? You want to make sure you're identifying themes in the literature and not just reporting on each individual study. That's not what we're looking for at the graduate level when you do a case conceptualization. What is the presenting problem, right? What's the client's affect? What's their content? What's their meaning? What's their history, right? What are their demographics, their biopsychosocial, cultural considerations. Then assessments, formal or informal. The MCE is always a good one to fall back on, as are the APA assessments. Then the treatment plan, right? What are your treatment options? What are your goals? What are the evidence-based interventions? And what's the prognosis or predicted change? I like to talk about readiness for change when I do this part, because I think it's important to know where the client is in readiness for change, because it has a lot to do with how the treatment's going to come out. And then ethical concerns. Being sure that you're actually citing the code of ethics, right? And making sure that you're using the code of ethics and not say a book that talks about the code of ethics. You need to actually go to the real code of ethics. And then reflection, like what are my strengths? What are my challenges? What are my goals from this? What do I hope to learn from this? What have I learned from this case? So these are all things you can think of when you're doing a case conceptualization. So this is just another outline, another model that you can use. It's based off of an assignment that I do in another class. So this is a really good way of thinking about how do I conceptualize my client. So that is the end of my orientation to case conceptualization. I hope that you find this a helpful video. We're going to post a couple of quiz questions in the quizzes. And if you could just answer those before residency, that would be really helpful. And then we're going to be doing some case conceptualization activities on the last day of residency. All right, take care. I hope to see you soon.